You're alive. You can go ahead now.
Good evening, everyone, and welcome to this very special event, the annual Sickle Cell Lecture, hosted by the Sickle Cell Support Foundation of Jamaica in partnership with the Ministry of Health and Wellness as part of our Sickle Cell Awareness Month. I am Moret Wright, co-founder of the Sickle Cell Support Foundation and your moderator for this evening's event. It is a privilege to have all of you here as we continue our work to educate, raise awareness, and support the sickle cell community. As many of you know, sickle cell disease is more than just a medical condition. It is a challenge that touches every aspect of life for those of us who live with it, our families, friends, and caregivers. But in the words of Maya Angelou, you may not control all the events that happen to you, but you can decide not to be reduced by them. This evening, we gather to embrace that spirit of resilience and be informed as we explore the innovative approaches and emerging therapies that are shaping the future of sickle cell disease management. So, as we prepare for a very informative and content-rich session, we will get started with prayer. I invite Ms. Keisha Pitto, author and member of our foundation, to open with prayer.
You guys are seeing me?
We're seeing you, Keisha. Go ahead.
Okay, thank you so much for having me on today. Such an honor. Good evening again, everyone. I'm just really grateful to be here. Thank you again, Miss. So the Sickle Cell Foundation team for putting this together. So let us pray. Heavenly Father, we come before you today, Lord, with gratitude, with hearts filled with gratitude, O Lord, in recognition of the Sickle Cell Awareness Month, O Lord. We thank you, Father, for the strength, the courage and resilience for those battling this illness. Each day, oh God, that you will continue to sustain them with your grace and your mercy. We thank you, Father, that you also lift up those who work tirelessly, oh God, to show and advocate for advanced treatments, for cures, oh God, and also the caregivers, the professionals, the ed care system, oh Lord. I pray, God, that you will bless the work of their hands, oh God, that it will bear good fruit, oh Father, as we dive into these innovative, oh God, approaches, oh God, and the therapies, oh Father, that it will bear fruit, oh God, so that we can live a more meaningful and fulfilling life, even though we are, despite the battle of sickle cell. Oh God, I pray, God, that you will bless the keynote speakers today, oh God, that you will give them your guidance, your wisdom for each conversations made today, oh Lord. And I pray, oh God, that you will continue, oh God, the work, oh God, that you will reach more global impact, oh Father, for your people, oh God. And I pray, Father, that you will just let today, oh God, be a testament of faith, oh God, for the healing power, oh God, because in your faith, Father, our faith in you, Father, improves our health, oh God. And you said in your word that by your stripes we are healed, oh God. And we thank you, God, that you are doing something new even on this meeting today, oh God. And we bless each and every one join today, oh God, that they will leave impacted, oh God, and more educated, oh God, in the awareness, oh Father, as we seek to push these forward, oh Father. We thank you, God, for these. In your name I pray. Amen and amen.
Amen and amen. Thank you so much, Keisha, for that powerful intercession on our behalf. Once again, I want to welcome you, each and every one of you who have joined us this evening. A special welcome to our distinguished guests, the Directorate and executives from the Ministry of Health and Wellness. Especially, I wish to acknowledge Dr. Carol Lord, Chair of the Sickle Cell Technical Working Group and National Coordinator for the Sickle Cell Program. You'll hear from her shortly. From the Sickle Cell Unit of the Caribbean Institute for Health Research here at the University of the West Indies, we welcome the team who join and the Friends of the Sickle Cell Unit, Friends of Care. And also want to acknowledge and welcome members and friends of the Sickle Cell Support Foundation of Jamaica. Our special guest and keynote speaker, Professor MONIKA ASNANI. Thank you, Prof, for agreeing to deliver this highly anticipated lecture and sharing your expertise with us. To our healthcare professionals, researchers, and I must highlight the members of the sickle cell community, our sickle cell heroes. We celebrate you today. This one is for you. Ladies and gentlemen here in Jamaica and elsewhere in the globe, we welcome you all. Your presence shows our collective commitment to improving the quality of life for individuals living with sickle cell disease. We're all champions. Sickle cell disease, as many of us here know all too well, is not a journey that can be walked alone. It requires a community of family, friends, caregivers, healthcare workers, researchers, and advocates. Together, we're stronger, and together, we can push forward to new frontiers in treatment and management. So with that, I would like to introduce Dr. Carol Lord, Chair of the Sickle Cell Technical Working Group from the Ministry of Health and Wellness, National Coordinator for the Sickle Cell Program at the Ministry, and Public Health Specialist to deliver her greetings. As you might be aware, since 2013, sickle cell disease has been included in the strategic plan of the Ministry of Health and Wellness in Jamaica. And Dr. Lord is that person charged with the mandate to implement the program. So let's hear from Dr. Lord.
Yes, thank you very much. Our moderator, Ms. Maureen Wright, co-founder of the Sickle Cell Support Foundation of Jamaica, our prayer warrior and author, the member of Sickle Cell Support Foundation, Ms. Keisha Pitter, representatives from the Ministry of Health and Wellness, University of the West Indies and the regions, our online guests, our Chief Medical Officer, Dr. Jacqueline Bisesa McKenzie, is online, our Director of Health Services Planning and Integration, Dr. Nadine Williams, our members of the Sickle Cell Unit, the Sickle Cell community, including the Sickle Cell Support Foundation members, warriors, and Shaq's Hope, our distinguished guests, colleagues, members of the streaming media, Mr. Leroy Bailey from Ministry of Health and Wellness. Ladies and gentlemen, good evening. Sickle cell is a genetic disorder that presents many challenges, not only for individuals living with the condition, but also for their families, caregivers, and healthcare workers who provide essential care. I want to take this moment to applaud the dedicated, hard-working healthcare workers all across the nation who work tirelessly in managing this condition. I want to say a special recognition must also be given to the Sickle Cell Unit at the University of the West Indies. For many years, this unit has been at the forefront providing stellar care for those affected by the sickle cell disease. With ongoing clinical and technological advances, we have more opportunities to provide quality of life for persons living with sickle cell disease. And so the Sickle Cell Disease Technical Working Group that was formed in 2014, which includes the Ministry of Health and Wellness, the Sickle Cell Unit, and the Sickle Cell Support Foundation of Jamaica was a significant step forward in addressing the needs of people living with sickle cell disease. And we can take a look at the needs assessment survey conducted and led by our own Professor Knight Madden and co-chair of Sickle Cell Technical Working Group. This survey was done actually among persons living with sickle cell disease and their caregivers. And it had some very startling revelation because we want to be able to provide care for persons living with sickle cell disease. And with this survey, we found that there was dissatisfaction with the social life, and there was challenges in completing education due to the disease. And so as we commemorate World Sickle Cell Month this year, we are taking tangible steps to address the findings, not only of the survey, but also of the cries of persons living with sickle cell disease. Today's activity is just one of that, aimed at improving the support system for persons living with sickle cell disease. We want to be able to help to shape the healthcare services for this vulnerable population. The management of sickle cell disease remains one of the most pressing issues, and Prof. ASNANI would be able to expound on that. Please listen out. Pain is one of the most common symptoms of the disorder and often lead to hospitalization and readmissions. However, today's event is special. What we want, we are trying to have an ongoing effort to bring attention to the care of persons living with sickle cell disease by having this important conversation. We will take a closer look how we can improve the lives of persons living with sickle cell disease. We have the National Health Fund card program that actually provides subsidies for all persons living with sickle cell disease and double subsidy for persons who are under 18. And so I want to say thanks again to the Sickle Cell Technical Working Group and organizing this platform for persons to be able to hear more on sickle cell disease. And so in conclusion, I want to say we are committed to making a difference. We want to be the catalyst in delivering high quality of care and support for persons living with sickle cell disease. I want to say thank you so much for having the Ministry of Health and Wellness to being a part of this body and to coordinating this body. And I pray that we have a very exciting lecture, empowering lecture. And so I bring you greetings again from the Ministry of Health and Wellness. Thank you.
Thank you so much, Dr. Lord, for your heartfelt words and continued dedication to advancing sickle cell care in Jamaica. We really appreciate all that you do for us. And now the moment that we have been waiting for. It's my honor to introduce our keynote speaker, Professor MONIKA ASNANI, Professor of Family Medicine and Epidemiology and the Director of the Sickle Cell Unit at the Caribbean Institute for Health Research Care at the University of the West Indies, UWI. As the Director of the Sickle Cell Unit, Professor ASNANI has been at the forefront of cutting-edge research and clinical care for sickle cell disease, both in Jamaica and internationally. She joined CARE in 2003 and has over 20 years of experience in clinical care for persons living with sickle cell disease. Her research focused on psychosocial outcomes, sickle, nephropathy, and maternal mortality in sickle cell disease. Her work has advanced understanding of renal function decline in sickle cell disease and validated tools to assess quality of life across various age groups. She is currently leading a study on barriers to hydroxyurea uptake in Jamaica and is a member of the World Health Organization Guidelines Development Group for Pregnancy Management in Sickle Cell Disease. A UWI graduate, she earned her MBBS, that's Bachelor of Medicine and Bachelor of Surgery, in 1992, and her Doctor of Medicine in Family Medicine in 2006, and a PhD in Epidemiology in 2014. She's also a supervisor, examiner, and board member in UWI's Family Medicine program, and a long-standing member of the Caribbean College of Family Physicians. We all agree that Professor ASNANI's work has been instrumental in shaping how we understand and treat this complex condition, particularly in our context, where it affects so many in our population. This evening's lecture, Innovative Approaches and Emerging Therapies in the Management of Sickle Cell Disease, will offer us insights into the advancements that hold the promise of reducing the physical, emotional, and mental toll that this disease takes on so many of us. As we look to the future, I'm reminded of the quote, "The best way to predict the future is to create it." So let us now welcome MONIKA ASNANI, Prof, who is helping us to create a future where sickle cell disease can be managed more effectively and with greater hope. So while you send her some love by placing your emojis in the chat, I just want you to note that right after the lecture, we will go into a session of question and answers. So please type your questions in the chat as they come to mind, and we will address them at the end of her presentation. So you've shown her your love. So welcome, Prof. It's over to you to deliver this keynote presentation.
Wonderful. Good evening, everyone. Can you hear me, first of all?
Yes,
Prof.
we're hearing you loud and clear.
Thank you. This started storming here a couple minutes ago, so it might be competing with me for voice. Moret, thank you so much. I don't know where you got all that information from, but we really need to edit it and make it to 2 sentences, because it doesn't need to cut into the main reason we are here. I also want to say one thing before I begin, because you know, it's amazing where I sit at sickle cell unit or interfacing with the sickle cell disease community in Jamaica and globally. But what I see of Jamaica, friends, everyone online, is absolutely unique, which is you're seeing the partnership between administrators and policymakers of the Ministry of Health and Wellness of the country. You're seeing the power of persons living with a disease and the voice of those people. And you're looking at the collaboration with healthcare providers, researchers, clinicians, etc. This is so unique to see in real time and in real world. I don't know if we realize, we know Jamaica has a lot of wins, in so many different areas. But I believe this is a huge win, not just what Jamaica has, how Jamaica has led the world of sickle cell disease knowledge and understanding, but this what we are seeing here, the partnership over the last decade between policymakers, the real stakeholders who are families and persons living with sickle cell disease, and of course, those of us who try to understand it and see what we can do about it. So I'm going to try to share, and I'm going to remove my video for now so that there is not much interference of bandwidth, and I hope we'll be successful. So Dr. Lord, other Ministry of Health and Wellness officials, Moret Wright, and members of Sickle Cell Support Foundation of Jamaica, all colleagues, friends, and the sickle cell disease family. Thanks for being here. I am sure that I'm not going to be saying anything that most of you don't know already. I know that, so it makes my life a little bit easier. But here it goes. So just to use the first couple of slides to lay a background, since it is a public lecture, so pardon me if you're a little bit bored by the first couple of slides. We speak to the sickle cell disease basic facts. And one of the first facts I have written there is that it is the most common monogenic disorders worldwide. Monogenic means it occurs simply because there is a mutation or a defect in a single gene out of, the hundreds of thousands that we have in our body. A single gene is mutated, and then this disorder occurs. This disorder affects the hemoglobin, which sits in the red blood cells. Red blood cells are one of the cells within our blood. So it's a multisystem disorder because blood goes all over our body. So it affects everywhere that blood goes, all the systems in the body. And it can be quite severe with many acute problems such as painful events, painful crisis, acute chest syndrome, and strokes. And
Barbara, we're not seeing the slides.
you're not?
No, we're not. I was just about to send a message.
Right.
All right, let's share again then. So I'm the only one seeing my slides. Are you seeing it now?
It's coming up now. There we go. Good to go.
Okay,
Excellent.
but now I need to get it into slideshow. Because when you share, you can't see half of your screen. Hide floating meeting controls. All right, so this is where I was. Nothing much that you guys missed. And we were speaking to here, progressive organ damage. So you can have acute problems and you can have progressive organ damage, which occurs with time, and damage can be any parts of our body, but especially the eyes, the brain, the kidneys, the heart, the liver. How is it inherited? We said it's a genetic disorder. There's no way to get it except to be born with it, and it is inherited from both parents. So if you have a parent who has sickle cell disease and the second parent has no sickle cell disease or sickle cell trait, you cannot be born with sickle cell disease. So the parents of a person with sickle cell disease must have at least the S trait or the full-blown disease. Here in the diagram, you will see two parents, the mummy here, I hope you can see my pointer, with AS, which is sickle cell trait, and the father here with AS as well. And then you can have an individual, a baby being born with sickle cell disease, what people call full-blown SS disease. You can have babies being born with sickle cell trait, and you can even have a child being born who has normal hemoglobin, no sickle trait or sickle cell disease. That is if two parents, a couple, is both carriers or sickle cell trait. And so trait versus disease, we said this, sickle cell trait is one normal hemoglobin, which is hemoglobin A, and one abnormal, in this case, hemoglobin S. So it's AS, whereas sickle cell diseases is a group of disorders, the commonest being when you inherit two S's, two abnormal genes, which are S, that is the SS disease. You can inherit one hemoglobin S gene and one hemoglobin C, which is another kind of abnormal hemoglobin gene, SC, and so on. There are other variants as well. There are multiple variants, the commonest being SS, followed by SC, followed by S beta thalassemias. So what happens when this hemoglobin is abnormal? These are your regular normal red blood cells. They look a little bit like donuts, and they are very, they are quite resilient, and they can maneuver their way through very fine blood vessels. But when you have someone who inherits the sickle hemoglobin and ends up being born with sickle cell disease, then these red blood cells, which look round and nice here in normal blood, can assume sickle shapes, the shape looking like a banana or a crescent moon, and they can really block up your fine vessels, especially, okay? Hemoglobin, what we talk about in the red blood cells, is the molecule that carries oxygen all around our body. And when you have these red cells sickling or assuming a sickle shape, then they can give a lot of problems. So it's not only the shape of this red blood cells that gets abnormal, but the whole characteristics, the whole character of the cell changes. All right. It becomes a very rigid cell, which means, and that is one of the main reasons why it cannot maneuver through very fine blood vessels. Okay. It becomes a lot more friable in that it can lyse or break down very quickly, whereas normal red blood cells can live up to 120 days. The sickled red cell will live for about 10 days, up to 20 days. So it's not only the shape, it gets very rigid, it also gets very sticky. So there are many different mechanisms how the sickled red cell changes. And in fact, the whole system, the whole vasculature of a person living with sickle cell disease undergoes a lot of different changes. So, you know, Ms. Wright said that I've been at the unit from 2003, and definitely there are people who have been at the unit for longer than that. Professor Knight Madden is one such person, Nurse Harris is another such person. And you would think that, you know, we're either very boring people who don't mind being bored looking after one set of problems day in and day out. And that's what I thought would happen to me, that as a GP, I would be very bored looking after one disease. But, you know, what has happened actually is that for years now, I've realized the disease is so variable. I'm not the only one who has realized that. The whole world of sickle cell disease realizes that the huge variability within sickle cell disease patients, it keeps us going. Like every time you think you're understanding something, there are 10 other things that are happening. It keeps you on your toes, literally, as healthcare providers, and you need to keep working at it. And whereas we think we have made a lot of strides, there is so much more to do. So there is variability between the different types of sickle cell disease. And even within the same type of sickle cell disease, it can be mild for one person and very severe for another person. So the disease is hugely variable. And as I said, it keeps us on our toes. It can, as I said earlier, because it's a blood disorder and blood goes all over, it can lead to a host of complications, possible complications. And you see some of them listed here. What is huge is that most doctors, nurses, patients, caregivers will understand the clinical problems. You know, everybody knows, oh my God, you can have really severe, painful crisis. And that's in fact the hallmark of the disease. You can have various organs that get sequestration, the pooling of blood in these organs, the spleen, the liver, etc. You can have stroke in young children. Young children, really a devastating complication. You can have life-threatening acute chest syndrome, and you can have damage to your kidney and da-da-da. But there's also, because it is a lifelong disorder, it's really a true chronic illness, it comes with a huge social, psychological, and a public health burden that we really need to face and address as well. And this slide will show you just a couple examples really of the social burdens that we face as a result of this disorder and the psychological burden. So socially, you know, children may have to miss school quite a bit more than other children who don't have sickle cell disease, and that can lead to lower academic achievement. Plus many other issues they may have that can lead them to lower academic achievement. And you can imagine how that progressive, even though we have superstars in the working world, our chair for this evening is one such person. We have doctors and PhDs, and we have managers living with this disorder, but really and truly, it can be quite a challenge in your academic pursuits. And a number of various other reasons can lead to lower socioeconomic status, because you can have workplace challenges, employment challenges, you might get sick events that take you away from work, etc. There are well described inequities in healthcare access around the world in the best of setups. within the region and within Jamaica as well, you can face inequities in access to healthcare, and there can be inequities in access to health insurance, etc. Number of psychological burdens. I think those of us, even those of us who have been working so long in the world of sickle cell, cannot fully understand the burden that is felt. So many psychological issues are possible: depression, anxiety, loneliness, poor coping, catastrophizing, because any of these events, any of these complications become life-threatening. The huge impact on the quality of life, how the life is impacted, the daily things that we take for granted can be impacted hugely for persons living with the disease. And other social well-being challenges, experiences of stigma, so unnecessary, so unfortunate, and really something that really, really angers me and most people like me, because this, the patient should not be experiencing any stigma. There's inadequate public awareness of the disease because it is still considered a rare disorder, etc. So there are a lot of burdens that individuals with this disease face, and these are just a couple that I've highlighted here. Just this one slide to provide a little context to what's happening with sickle cell disease in Jamaica. Nothing much has changed from the time that, I went to med school 35 years ago. No numbers have really changed, but 10% of the population in Jamaica carries the sickle trait, the S trait. And 5% of Jamaicans or people living in Jamaica carry another abnormal hemoglobin. Remember, I spoke about hemoglobin C or the beta thalassemia trait. Okay, so that's 15%. So if we have 45 people in the room, we might have 3 of us who are carrying some kind of a trait. To date, out of every 150 infants that are born live, one of those babies is born with sickle cell disease. So 1 in 150 live births in Jamaica continue to be born with sickle cell disease. And we estimate, and this really is a guesswork because we don't have a precise registry to tell us these numbers, we estimate about 18 to 19,000 persons in Jamaica living with the disease. Median survival is just about 42 years. Which is not 2 to 3 decades, it's 3 decades less than our overall Jamaica population survival. Mind you, this does not mean that people will not live beyond 40. We have many, many people living in their 50s, 60s, 70s, and 80s, okay? And we do have, unfortunately, those who will not survive childhood or younger adulthood ages, but this is the median survival. Unfortunately, maternal deaths continue to be impacted by the presence of sickle cell disease. So out of 100 for sickle cell disease, it leads to 378 deaths per 100,000 live births. And it's the maternal death rate is about 4 times that in non-sickle cell women for Jamaica. But a win is that if you have a baby diagnosed at birth, because now we do have newborn screening all through Jamaica, where 99.9%, almost 100% of births occurring in Jamaica are tested for sickle cell disease at birth. And once a baby gets diagnosed and once that baby enters into our early childhood care system, then the childhood mortality is no different than in non-sickle cell children. I just want to say, why is this so important to us in the sickle cell world? Because just to give a background, in sub-Saharan Africa, where close to 80% of all babies are born annually, okay? 50 to 90% of those babies born in sub-Saharan Africa will not see their 5th birthday, unfortunately, because newborn screening is not widespread and provision of early childhood interventions such as penicillin prophylaxis is therefore not highly utilized. Let's move on to managing sickle cell disease. This is what Moret and Sickle Cell Support Foundation really charged me with. Again, not anything magical I'm going to be telling you about, but if you talk about the actual therapies, they are the older, what I'm calling well-known therapies, hydroxyurea, blood transfusions, and hematopoietic stem cell transplantation. And then there are the newer ones. And it's amazing that these newer therapies, L-glutamine, crizanlizumab, voxelotor, and genetic therapies have all come on the market 2016, 2017, and the last one being 2023. And I do want to use one or two slides to speak to non-pharmacological treatments. So hydroxyurea is the first drug that was approved for the management of sickle cell disease, and only in 1998. And for 20 years, it was the only drug on the market for sickle cell disease. So you see the inequities in care and even research and development of technologies for management. And hydroxyurea, however, is a God-given drug. It seems to be tailor-made to attack all the problem arms of sickle cell disease itself. So it promotes the production of fetal hemoglobin. Fetal hemoglobin is a hemoglobin we have in our bloods when we are in the mummy's womb and for a couple months after birth. But we know, we have learned that if you have higher levels of fetal hemoglobin, then you don't sickle as much at all. Fetal hemoglobin can block sickling, and hydroxyurea does exactly that. But it also has a lot of other effects. I told you that sickle cell disease comes with adhesions or stickiness. It reduces that. It reduces inflammation. It improves how those red blood cells behave. And it improves nitric oxide in the blood, which allows blood vessels to dilate and allow for easier passage of blood. And just to say that in both in adults as well as in infants, it has been shown to reduce by half. And there is a huge amount of data and a huge amount of knowledge about all the good effects of hydroxyurea and sickle cell disease. But in both children and adults and infants, there is massive good effects on painful events, acute chest syndrome, etc. Our studies in Jamaica have shown that we can use hydroxyurea in children at risk for stroke, or those children who have had strokes, who then become at risk of having second and third strokes. All of those things are really, really helped very well by hydroxyurea. All in all, it's shown to improve survival as well. This is just a very basic slide, but the data on this is huge. It's an excellent medication. It's a simple once-a-day tablet to be taken by mouth. The medications are pretty well available. We worked well together as a sickle cell technical working group, the unit, the ministry, the support foundation, to get sickle cell added onto the National Health Fund. So now the drug is subsidized since 2015. Sickle cell disease was added to the list of chronic conditions that NHF covers. And remember, NHF provides a double discount for children. So hydroxyurea is one of the main drugs listed under sickle cell disease. It does require close monitoring, especially in early treatment. There may be the possibilities of short-term toxicities. Mostly they are mild and totally reversible. We still do not recommend its use in pregnancy. Want to show you this slide, and this is a slide showing us some numbers from the National Health Fund. Their drug formula, remember I said this was added in June 2015, but data at 2024. If we estimate 18 to 19,000 people living in Jamaica with sickle cell disease, only 3,000 have enrolled on the NHF as of March of 2024. That's 9 years later. So that's not good, guys. All doctors and nurses anywhere in Jamaica, please encourage your patients to go and get registered with the National Health Fund. You don't know which day you might need to use it, if not all the time. Hydroxyurea, one of the problems worldwide is that there's just underutilization of this huge drug, which seems to be tailor-made for sickle cell disease. And there are many different reasons around the world where that underutilization might occur. It may be due to availability our accessibility of, say, liquid formulations. Even in Jamaica, we do not have a liquid formulation that we can use in children. But in Jamaica, many pharmacies will create suspensions, will form suspensions for children's use. There is one of the main issues is hesitancy on part of the healthcare providers in recommending this drug. They might have low self-efficacy, low awareness of its benefits. They might think that the patients are going to have a financial burden, and so they don't want to use it. They think that patients are not going to be compliant with every day taking a medication, etc. We are doing our study to see what are the particular issues within our setting. I'm not going to present those numbers here today. And there is hesitancy on part of patients and families as well for many similar reasons. And once it is begun, even then we have issues of adherence, which can be for various reasons. So we need to continue to work on this, because guess what, guys? Guess what, Sickle Cell Support Foundation, this still is a game changer. One slide on transfusion therapy, blood transfusion therapy. If we say blood in sickle cell disease patients has abnormalities, then changing it by adding normal non-sickle blood can really reduce a lot of the problems. And really, red blood cell transfusions is the first therapy used in sickle cell disease, and definitely the gold standard for many conditions and many complications of sickle cell disease. We know very clearly that it reduces complications, improves quality of life, but it has a lot of its own problems. And each one of you can name the same problem. In Jamaica, we just do not have a good blood supply, you know. But there are other things. When you keep getting blood transfusions, there's a risk of reacting to the blood coming in from other donors. As the more you get transfused, the more that risk increases. And there are methods of reducing that risk, but a lot of those methods are not available all over the world, especially in lower and middle income countries, and in Jamaica as well. There can be reactions to transfusions, and there's risk of infections, but if blood is tested well, which it is in Jamaica, we should not have those problems. But definitely there's a risk of iron overload, which can be a huge complication of its own, and it can be pretty expensive to manage. The more blood transfusions you keep getting, especially without doing exchange transfusion, you can get overloaded with iron, which can have severe effects on multiple organs in our body. And so that becomes a problem of its own. This is one of the older treatments now, because it was first used in 1982. And this is what we call hematopoietic stem cell transplantation, or bone marrow transplantation. But in all these years, just about over 2,000 transplants have been done worldwide. Definitely, we have no such facilities to do it in Jamaica or in the wider Caribbean, except overseas territories.
Oh, still in it.
Sorry, can you hear me? Hello?
Yes, Prof. Yes, Prof. We're hearing
Okay,
you.
I thought I heard something.
Continue.
Thank you. But you do, for bone marrow transplant, you do need preferably a matched sibling donor, and only about 15% of population with sickle cell disease will have that. But researchers and clinicians have been working hard over the last few years to see how these limitations can be overcome by using a half-match donor, etc. But survival after a bone marrow transplant, the numbers are getting better and better every day. In fact, it is very good, but there is a real risk of what we call graft rejection. The way we have been built, if any foreign body is put into our body, there's always a risk that we'll react strongly to get it out of our system, right? And that's what's called graft rejection, or graft versus host disease. It can be managed, but these are some of the problems and some of the limitations. Yet, I just want to say that it is a really good option it's a curative therapy. This again is not new news anymore, but there still are newer frontiers in the management of sickle cell disease. And these three therapies were approved. Sorry, I told you the wrong dates. 2017 for L-glutamine is marketed as Endari. 2019 for Voxelotor, Oxbrita by Pfizer, 2019. Can you imagine 1 year, 2 new treatments came out, voxelotor, crizanlizumab, both FDA approved in 2019. So these are the 3 new drugs. And if you look at it, L-glutamine is really an amino acid. It causes reductions in painful crises and hospitalizations. It's taken twice a day as an oral powder. Voxelotor is a once-a-day drug. It increases hemoglobin levels and reduces markers of hemolysis, means less of a breakdown of red blood cells is occurring when you take voxelotor. The crizanlizumab is a once-a-month intravenous IV infusion. It causes reduction in vaso-occlusive crisis. But look at the last sentence. Just recently, a few months ago, it is within 2024 that the license by the EMA, which is the European Medicine Agency, has been revoked because in real-world data, crizanlizumab has been shown. So it's one thing when you do clinical trials under some robust conditions versus when it comes out into the market, into the real world use of this drug. And real world data is showing to date that crizanlizumab is no more effective than not using it, okay, to put it very simplistically. So actually its use in license in Europe has been revoked, still being used in the United States. But if you look at it quickly to say, and these are United States figures, starting dose hydroxyurea within many countries now, it can begin from childhood, from infancy as young as 6 months of age, L-glutamine at 5 years, crizanlizumab, 16 years, voxelotor as low as 4 years. And I just want you to look at the age, the annual cost. In the United States, hydroxyurea can be up to $2,000 a year, but look at how the costs go up. And there are many other drugs that are being investigated rapidly over the last few years. They all work on different pathways and different mechanisms by sickle cell disease causes these problems. And there is hope in these new drugs being developed. In Jamaica, what's available for us in Jamaica? Hydroxyurea is the preferred treatment. We said already the chronic blood transfusion program is not employed because of the limited supply of blood. Of course, when an individual, a patient needs a blood transfusion for acute problems, they come in and the hemoglobin is really low, or a baby or a little child comes in and all their blood has pooled into the spleen and the hemoglobin gone down to 3, then obviously they need to get blood quickly. But a chronic transfusion program is not involved, it's not employed. We said there's no bone marrow transplant facility in Jamaica or the region. And I'll be talking to Gene Therapies in the next slide. And those are only available through trials. And this again reiterates what I said in 2 slides ago. L-glutamine, crizanlizumab, voxelotor, not available not only in Jamaica, but most of the Caribbean. L-glutamine is really an amino acid, and it is available in health stores, not the branded Endari at the proper dose that was tested for sickle cell disease, but it is available in health stores, and the monthly cost in Jamaica would be equivalent of US $100. Hydroxyurea for an adult patient, hydroxyurea is a weight-based dosing schedule. So it's for a dose for an adult and a child would be very different. So for an average 60 kilo adult at an average dose, because doses can vary between 15 to 35 milligram per kilo and even lower, you are thinking of paying with the NHF subsidy close to maybe just about $20 US. We, the sickle cell unit, was engaged in clinical trials of crizanlizumab and voxelotor. It is not licensed for use in Jamaica yet because we really are awaiting real world data to see whether it is going to be useful to bring in Jamaica. Looking at 2 slides on cell-based curative therapies for sickle cell disease, and this is gene therapy. Oops, how did this slide get here? So gene therapy avoids, or it overrides many of the limitations of a bone marrow transplant. For a bone marrow transplant, which we know is curative, and we have 40 years of literature for bone marrow transplantation in sickle cell disease. But the limitation is, remember, I said only 15% of patients living worldwide with sickle cell disease might have a matched sibling donor. For gene therapies, there is no need for a matched donor because it is what we call an autologous transplant. Is coming from your own body. Okay, so two big problems are totally dealt with through gene therapy. You don't need to find a donor and have that donor matched. And remember, I said earlier, the graft versus host disease, even if your sibling is very closely matched to you or fully matched to you, you can still have there's a real risk of rejecting it because it is still foreign material. It's not what God sent you down with. That liquid blood stem cells coming into you are still foreign. But with this gene transfer, there's no risk of graft versus host disease. It is also like a bone marrow transplant, a one-time permanent correction, etc. Won't say much more on this, but lo and behold, two gene therapies were approved in December 2023, made by two totally different companies and two totally different mechanisms. The first one, Casgevy, licensed by Vertex, is based on CRISPR-Cas9 gene editing technology. We all have been reading about CRISPR and Cas9, etc. And Lyfgenia, which is a gene addition cell therapy, both got licensed, FDA approved and licensed for use in the United States and elsewhere. Look at the cost. It looks humongous. US 2.2 million for the Vertex CRISPR product and 3.1 million for the Bluebird Bio product. It looks huge, yes, for a one-off cost, but if you really add on, I mean, the justification that these companies are using, and they're not lying, is that a person living with sickle cell disease over a lifetime can incur costs in the millions as well, just dealing with the disease. So, we in Jamaica have no access to this yet. We have been part of a gene therapy trial where 3 of our patients from the sickle cell unit have benefited through that trial, and it's not one of these 2 trials. We have 3 of our patients who have gotten the gene transfer therapy. The first one is 7 years into gene transfer, and they are doing fairly well. So we leave it at that for now. Looking at my time, and I think I'm doing okay, I think. I want to speak to 1 or 2 slides on non-pharmacological treatment. The next few slides till I end are really taking a different look. I know we love to hear about, drugs and magic and cures, but it's not that simple. Management of a chronic disorder is not that simple. And even with genetic therapies or bone marrow transplantations, patients can have massive improvements in their quality of life, but they do need to be followed up because there are other issues we need to be dealing with. But while bone marrow transplantation and genetic therapies and other drugs become available to most people in the world living with sickle cell disease are living in lower and middle income countries. As I said earlier, 80% of annual births, and we estimate now close to 500,000 births a year happening worldwide with sickle cell disease. 80% of those are in sub-Saharan Africa. Next high up is like India. The population there is huge. And the Caribbean is second in its incidence rate, second only to sub-Saharan Africa in the incidence or birth rate for sickle cell disease. So we need to understand and we need to employ, I think the next few slides are more important to me than what I've said earlier. So let's talk about non-pharmacological treatments. I said already pain is the hallmark of sickle cell disease. Pain in sickle cell disease is a very complex problem. Okay, it's a very complex problem. It's not a broken bone. It's not, you get an infection in your finger and it gets really crazy painful. It is a very complex set of mechanisms, all of what is not being understood. It's a complex problem, and hence it requires a complex multimodal management. Doesn't mean the complexity here doesn't mean that we can't handle it. We just need to realize that it's a multimodal management. And if you look at the little picture I have on the right side of the screen, you will see that to optimize the management, here we speak to chronic pain or recurrent pain, then you need not only people who are experts in sickle cell disease, like those of us at Sickle Cell Unit, but you need care coordinators, you need support from mental health services, you need to have the support of community-based organizations like Sickle Cell Disease Warriors and Sickle Cell Support Foundation. You need any teams engaged, you need pain specialists engaged, you will need physical therapists, primary care provider teams, maybe rheumatologist teams, sleep specialists, social services, and other community resources. Your schools, your teachers need to understand, your workplace needs to understand, and everyone together. It's not that difficult. It looks complex, but it's really doable. Okay, because as we try to handle pain, as we learn more about pain, that there are many coexisting psychological problems that go along, especially in pain in sickle cell disease and many other social problems. And if we don't touch those, and if we don't address those, we are not going to get a handle on managing this pain. So for example, there are very positive effects in those groups of people who have good social support. Okay, we've had patients, especially adult patients, who say, boy, doc, we can't, like tell my family about pardon. All my friends laugh at me for my poor patois, but forget that. But when patients come and say, I don't want to tell my family all the time, my God, I'm having pain again, pain again. I'm tired of saying it to them because they're tired of hearing it from me all the time. That reduces healthcare utilization at a time when they really, really need to get the care, you know. So simple stuff like that becomes a really complex problem. So many positive effects when people have good social support. There are coping strategies that many patients have shown us they use and they benefit from. Look at it in the next slide. The panel on the left says, this is our Jamaican data from one of the earliest studies that Dr. Ramsey and the team at Sickle Cell Disease led, Sickle Cell Unit led. And these were the non-pharmacological treatments our sickle cell disease patients said they used to manage their pain. Distraction. Just about half of the people we studied, and it was a large study, about 280 or 270 people that we examined in this study. Almost half said they use distraction. So when you doctors or we doctors see people laughing and sitting out there, and the minute they come into our office, they say, boy, I'm having the worst pain ever. And we say, Lord, what a liar this is, because he was sitting out there quite jolly, laughing and going out with the nurses or this family. They use distraction, and 77% say that distraction is an effective method of managing pain. Other modalities that people are using, massage therapy, sickle cell support clubs, physiotherapy, etc. And on the right panel, I'm just making a couple of points. Many non-pharmacological treatments have been tried and can be successful for both children and adults. Cognitive behavior therapy, we hear about this in many different aspects of healthcare, can be effective in managing sickle cell pain as well. And there are many other methods. Most of them don't have very good clinical trial-based data, but sometimes that's not so important as what our patients are telling us. Use of heat packs, cold packs, distraction we said already, music, guided imagery, hypnosis, acupuncture, biofeedback, yoga. All of these modalities have been used by different groups and different patient groups, different parts of the world, and have shown benefits. You know, we can have a full lecture just talking about these non-pharmacological treatments, and maybe we'll do it one of these days, because they can be useful, but we need to get there as well and have these support mechanisms available for our population. Many of these approaches work through increasing the level of endogenous endorphins. We know what endorphins are. These are chemicals in our body that give us good feeling. Sexual activity is one that can release endorphins. Eating dark chocolate can release endorphins. Anything that makes us feel good can release endorphin, and we know they have analgesic effects. And many of these psychological treatments, as I said earlier, still require further evidence and further study. These are some little off-track slides, but I think they are very, very important slides for all sickle cell stakeholders to hear. People like us who are here listening to this talk or sharing in this talk. The Lancet Hematology Commission was assembled, the Lancet Hematology Commission on Sickle Cell Disease. The Lancet is a one of the hugest and most respected journals in the world of medicine. And they assembled this commission who highlighted multiple concerns, and this was published just 2023, the major global concerns and the global strategies that they have identified to improve outcomes in sickle cell disease. They say get more data, okay? Get more data, because when we see data, we understand things, right? Large numbers of people with sickle cell disease are neglected in countries, especially countries where the hugest burden of the disease is. Screen for the disease and prevent problems, okay? There's lack of consistent and sufficient funding, especially in these high prevalence, low income countries. We need to have organized newborn screening, find out who has sickle cell early and start them on their management plans. Establish and do further work in establish and emerging treatments. We spoke about all of them today, right? We spoke about hydroxyurea, blood transfusions, and we spoke about the newer drugs. Continue. See one here, poor access to safe blood transfusions is a problem that has been identified. Poor access to affordable hydroxyurea, improve those kind of things, improve and have comprehensive national sickle cell programs, which Moret has very proudly been highlighting, because Jamaica does have such a program. Cellular therapies, because they could be so useful in the coming future, and they're not far off. In fact, they have been licensed for use since 2023, and bone marrow transplant from way earlier than that. And look at this fifth one, this important strategy, part of what we are doing today as well, training and educating healthcare providers. And I won't say only healthcare providers, but I'll say all stakeholders, which the most important stakeholders are people living with the disease, their families, and the communities they live and work in. And this is their recommendations. And this slide I had done for an earlier lecture, that Jamaica's scorecard is doing pretty well, because we at least have made some steps into all of these strategies, the recommendations that the Lancet Commission has laid out. I think this is second to last slide, I believe. So how do we really manage sickle cell disease? I think we want to hear about new therapies. Yes, and it's important. I'm a doctor, I'm a scientist. I want to know that research continues full speed, and even, on even fuller speeds. Continue to grow the field and continue to see how we can really get a handle on this disease. So that work must continue, but we must not forget the important lessons that we have learned in the last few decades. Don't forget it, guys. Newborn screening and enrollment of sickle cell babies identified through the newborn screening into a comprehensive care program is critical to save lives. That so should be true. We said that 50 to 90% of babies will not see their 5th birthday if they don't have this, right? Babies die and we didn't even know it's sickle cell, but it is sickle cell, okay? Know your status, because that's the first step as well, okay? Newborn screening is screening babies at birth, but if you know your status, and that's our mantra, that's our tagline at the Sickle Cell Unit, know your status. This is a one-off test. It's not like your blood pressure numbers or your diabetes numbers or your HIV status, which you should be testing at least once a year, right? Once you know your sickle cell status, you know it for life. It's not going to change. And with countries like ours, where there's a high prevalence rate, then each individual especially young adults and adults who are looking to have children or not looking to have children, because a lot of babies are born without plan, should know whether they have the trait or the disease and understand what it means. So the third point is understand what your results mean. And more than that, understand the disease. So you, and I'm not talking you meaning healthcare providers, I'm not talking you meaning policy makers, I'm not talking you meaning people living with the disease, I am talking you meaning we as the world, as humans, so we can all be advocates for families and communities that are affected by the disease directly. Okay, each one in some way is directly is affected by the disease, but especially persons and their families living who have the presence of this disease within their midst are affected very directly. And for those who are affected directly, understand the disease so that you own the management of your disease. Don't let no doctor or nurse tell you otherwise. You own the management of your disease. Routine health maintenance visits are crucial because that's when we can pick up problems before they become unmanageable. Okay, screening for complications such as stroke. We can actually screen for stroke through a simple ultrasound test called the transcranial Doppler and pick up children, young children who are at risk of stroke and put them on treatment that can prevent them from having a stroke. Isn't that amazing? Screening for other complications early before they become critical. Address the psychological and social burdens of the disease. Otherwise, we will not have a handle on the problem. And this one, become critical partners. And this is especially directed at people living with the disease and other immediate stakeholders. Become partners in decision-making processes at the national level, advocating for political commitment into this disease. I think we have been pretty successful in this. And I know you guys are going to say every time you ask ASNANI to speak, she's going to bring in the word research, but partner in the conduct of research. More and more researchers globally are understanding this, but for me as a GP, it has always been a given. My patients need to be key partners. How successful we are with that is a process and it takes time, okay? But don't just be a passive participant when, you know, a researcher from the clinic calls and says, hey, we're doing this study, can you participate? You know, you become passive participants, or the recipients. All right, my research found you need to take this medication and you take it. Not only as passive participants, but become partners in identifying critical gaps in the understanding of sickle cell disease and identifying the needs of your own particular communities, right? And bring them to these teams of researchers and say, listen, man, it's important to understand this problem. What can you do about it? So become partners and then become partners in determining the actual process and the actual procedures for the conduct of research. I don't know how many of you believe me, but we can have another talk about this. But becoming critical partners is key. You know, just this morning, we were in a WHO-led forum. They are putting out some new guidelines for management of clinical trials. And this was so strongly highlighted that we really need patients, those directly affected by and living with any disease, because they weren't talking about sickle cell in particular, of course, to be full-on partners, because guess what? That's where the buck stops, right? They're the ones who are the most important reason for all of this that we are doing. Thank you so much for listening.
Wow, 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 wow. Thank you so much, Prof. ASNANI, for such an excellent presentation, informative, engaging, and hopeful. I will quickly read a few of the comments that I have here on YouTube. So Deborah Abrams from the UK says, very interesting and informative session, joining from the UK. Michelle Hamilton, excellent presentation, Prof. ASNANI. Marcia Graham, Prof. ASNANI is quite good at keeping us informed. And I'm seeing someone saying, Kino Sayeno, saying bravo. Sandrina Davis, very informative. And Asma Ali, great talk, Prof. And it's excellent presentation, Prof. Asnani. And right here, I'm seeing on Zoom, congratulations.
Just correct, because you
Very
have in the back.
informative global presentation. So we're now gonna engage in another element of our discussion. We want to hear from you. You all attest to the excellent content that was shared by Prof. So we want to field some of your questions to advance the discussions and explore further what she has already shared on the emerging therapies, how that will affect us currently and in the future. And I'm particularly interested in the non-pharmacological treatment strategies. I want us to talk some more about that. Currently, Prof, what structure do we have at the unit or that exists here that advance the non-pharmacological treatment that have been suggested or shared with us?
Yeah, excellent question. And I'm so happy to see a person living with the disorder herself asking such a question, because you know the importance of it. So, and I, for any question or any discussion that's happening, if you don't mind, Chair, I would invite my team members from the Sickle Cell Unit to jump in, okay, to jump in. There's Prof. Nyman and Dr. King, but others who are here, Nurse Grindley, I mean, the names that I'm seeing here, I'm not seeing everyone. Jump in and offer your comments as well, because I think my nurses know a lot more than we do many times. So we have a social worker, you know, we have been very lucky to have a social worker that post is filled free of cost to us at the university by the university hospital. And we have a full-time social worker who assists people who the clinical team identifies as having social needs. And we have said that those with huge amounts of social need might be very much at risk for more severe disease and outcomes. So definitely that is a person who provides support at many different angles. And I don't know if people living with the disease and others like healthcare providers understand that the social support is not only to pay for school books or to get some food together, which all will lessen stresses, but they are also have the ability to link to psychosocial support, etc., and ease many of the other social stressors that that these individuals may be undergoing. I know that the unit has worked hard. Dr. Chin leads this effort, Dr. Nikki Chin. She's passionate about really getting a psychology service going full on, where we can make easy links for that mental health support for individuals we identified really who need that more than others, okay? And I know we are working, she and Dr. King, we are working to see how we can effect that service, okay? In the meantime, of course, the unit will refer you, and as will all other physicians anywhere around Jamaica. In the public healthcare system, I know mental health services have been identified and listed. Ms. Wright, we had promised ourselves that we will actually create that list and share it with people coming to the unit and people in our support groups and so on. But there are mental health services available in the public health system as well that can be accessed and sourced. Now, talking in particular about setups of, say, providing yoga therapy or acupuncture or biofeedback or CBT in a real coordinated manner for persons living with sickle cell disease, you know the answer to that. That does not exist yet. That does not exist yet. But we hope that through forming these linkages with mental health specialists and others and psychologists who affect CBT, etc., that we can start to build that kind of a support system. And I like to say that this is not only for people living with sickle cell disease, but other individuals with other problems who will benefit from these services. I don't know if anybody else or Dr. Lord, as the lead for sickle cell disease program nationally, want to add on anything to it.
Thanks so much for that, Prof. So Dr. Lord or any other of the members at the unit who want to support Prof. ASNANI?
Yes, if I may, in terms of the mental health services, at the Ministry of Health and Wellness, we have the helpline that they can call. Yes, for immediate help. If they need help immediately or they can speak with a psychologist, and then if they need further referral, she will give them the referral. Over.
I think we have an opportunity for a coordinated CBT program. So that's something colleagues not sure what just happened. It seems as if there's a power outage or something went wrong just now. Prof. ASNANI, you there?
Yes, I just I wonder what happened.
Right. This is a mystery.
Yeah, I mean, my screen just said host ended the meeting, so I don't know if it was.
Sure what just happened. It seems as if there's a power outage or something went wrong just now.
Yes. Yes, Moretta, I see a few people on.
So the question though is, will the stream continue?
I just said host ended the meeting, so I don't know if it was.
He's trying to connect back to this to the streaming. Don't know what happened, but thank you so much, Professor Nani. That was great. Always appetite, a great appetite.
Sorry about that. I wonder what happened.
Yeah, I don't.
All right, you can go ahead. We are live again.
Right, we're live.
Okay, so welcome back. We are not sure what happened, but we thank you so much for rejoining as we continue with our question and answer session during this live. I think we were talking about the non-pharmacological treatment options that are available in managing sickle cell disease. We wanted to, explore a strategy where we can be a little more intentional and be more coordinated in some of these options that can be made available for sickle cell disease. And we would want to explore that with the ministry, that this be incorporated in the sickle cell program. You were making a point, Prof?
I was saying that I agree with you 100% that we need to have a coordinated, focused kind of a program. So I know the unit is trying to work on that, but with the 100 other things that we have, and we really are only able to reach out to people who are able to do some kind of voluntary service, with our people. So, but I think if we really hit at it, and I believe it's critical, it can really reduce so many of the problems that land people in hospitals, etc. So,
and you made the point, you talked about it anecdotally, where persons are sitting, waiting in serious pain, and they're just chatting as a means of distraction, a source of distraction, just to cope. So, yeah, that's something we can look at. And there's another thought that occurred to me, and we're back at hydroxyurea. And from what you have presented and from other research and presentation, it's not recommended for pregnant women. So it's used to manage the pain and it's used to manage the complication. And during pregnancy, you're prone to being more severe pain and having more severe complication. How then do you rationalize not using it during pregnancy?
This is where we are. Hydroxyurea is actually a very old drug. It was not developed for sickle cell disease. It just happened to show huge benefits in sickle cell disease. It's an old drug. It's an anti-cancer drug. It fights cancer, okay? And, a lot of cancer drugs are pretty powerful and they can have effects on a pregnancy, on the developing fetus. So that's the risk we worry about. How is it going to affect the baby coming, that is growing and developing in the womb? But in the 35 years of use of hydroxyurea, a lot of women have gotten pregnant while taking hydroxyurea. And really and truly, as data is building up, as our knowledge is increasing, or what we are seeing is becoming clearer, really not identifying these adverse effects in the children or the babies being born with sickle cell disease and as they're getting older. Now, we still, the unit is pretty, we don't like to be extremely bold in causing, risk or potential risk. So we are pretty conservative, but they are centers. So if a woman is taking hydroxyurea because of severe complications, which is what a lot of people go on it for, even though you can go on hydroxyurea simply because you have sickle cell disease, even if you have never felt pain, because the way hydroxyurea works and the way sickle cell causes slow progressive damage in the body, hydroxyurea will limit all of that or lessen all of that. We know that. But for a woman who is gone on it for severe pain, you are 100% right, and you get pregnant, even if you have never had a painful crisis, it may be the first time you end up in severe painful crisis when you get pregnant. So if this woman wants to get pregnant and she does not want to stop hydroxyurea and is willing to take that risk, there are many, many centers. Once counseling has been done, once these discussions about the benefits and the risk of hydroxyurea have been spoken, then that team of healthcare provider and the woman, and plus or minus our husband and family, can make that decision and go along with it. As long as we understand that the potential risk exists for the baby, even though it's not been seen in babies being born to women who just by chance, a lot of women get pregnant without realizing it.
That's correct.
In Jamaica, up to now, a lot of women might still feel that, well, I have sickle cell, I won't ever get pregnant. It's a myth. I forgot to put up the myth slide. So women will get pregnant while they are taking it and hasn't shown much damages. But science is not at a place where most doctors are willing to prescribe it during pregnancy. We still say hold off during pregnancy, and we do everything else that's needed. What can work well is blood transfusions in pregnancy. So pregnancy is a small period. It's not like it's not 20 years. Extended, it's 9 months or 6 months of really bad problems, because really in the second and third trimester and immediately after pregnancy is when most of the sickle cell complications occur. So research is ongoing. And we really need to, again, work with voices like yours and people like you, who are people living with the disease, to hear what your concerns are and how you make sense of what we are telling you. Because you might say, well, doc, have that discussion with me and let's have that conversation.
Right. That's right. That was my question. What, is this option presented to the pregnant mother and a decision taken by the mother? Or is it that because of the concerns then it's not presented as an option to continue, because the literature says it's not taken during pregnancy. If you're on it, once you become pregnant, then you should get off hydroxyurea.
I asked this question of our obstetrics specialists, especially those, a sickle cell pregnancy is a high risk pregnancy, and they go to high risk antenatal clinics. And Jamaica, through the PROMAC program, over the last few years, has trained enough of what we call maternal fetal specialists, and they're all around the country now. Dr. Lord can tell us more because she leads that program as well, the maternal health program. And having spoken to one of them up to late last week, she said the same, that once women are pregnant, we still maintain what the guidelines say, which is advise them to come off hydroxyurea. Because of limited understanding, that's all we can do. But I think we need to get to a place maybe where we start having some real good discussions, especially for women we identify to be at risk for problems during pregnancy. The problem, with hydroxyurea is, it's not like you go into severe pain and you give them hydroxyurea and it starts work right away. It can take a couple of weeks or longer to really start showing good effects. So it has to be something a little longer use. So to be continued.
Okay, Prof. I think your camera is off though, Prof.
Yes, it is. It is. I was getting a few glitches, so I took the camera off.
Okay. So talk to us a little.
If I may.
Yes, Dr. Lord.
Just
Continue,
to
please.
say that the obstetricians, the specialists, even in developing the guideline development committee for obstetric emergency, has indicated that we should come off of the hydroxyurea. They should come off of the hydroxyurea once they become pregnant. It should be discontinued.
Yes.
Over.
Because that's the existing guideline.
Right.
Right.
And that's where we are saying that maybe we need to have some really good discussions and move this forward a little bit.
And in recent times, I was having some conversation regarding that, and I've heard of mothers who have had strokes because during pregnancy because they've come off HU.
Yeah.
So I think and the research is advancing because at the conference on Friday, more information would have been shared in that regard. So I know, Prof, that you will advance on that particular matter.
It's a particular area that I am really concerned about. Dr. Crossdale had her hand up. She might have something to add to this conversation.
Okay, unmute Dr. Crossdale.
Sorry, I was looking at it in terms of being a neonatologist in terms of when they actually start the hydroxyurea. And I haven't looked at all the research or the period in which it is given, because when the fetus is developing, that's not the stage you'd want to be given hydroxyurea. So I'm not saying it can't be used, but there are certain phases, the early stages, that there would be some hesitance in a mother being on hydroxyurea. And I agree, you can give her the option if she wants to take it or not. But I think that's a concern I think most persons would have, because that's when it's more likely to have the more severe effects. And it can be later on, because it's a cancer drug. So I just wanted to put my opinion on the use of it.
Yeah.
Thank you so much, Dr. Crossdale. We appreciate your input. Dr. Lord, you're adding?
No, I was just saying that the obstetric guidelines say it should be discontinued, and this is from the guideline development committee, have the obstetricians and fetal maternal specialists from all across Jamaica. Right. So I think we can take that as a guidance document.
So that's the current state. And we're saying that we want to interrogate that state some more and see whether or not we should maintain that current state. I think that's where we're at.
Absolutely. Absolutely. That's exactly where we are.
But we need to have the evidence. since it's evidence-based.
It's a little bit difficult to do clinical trials on this kind of a drug in pregnant women. Likes of Prof. Knight Madden, and I don't know if Professor Troutman Edwards is on the call still, are going to shoot us down. That kind of research is difficult to get ethics approval for. So we're really just looking at real world data and other studies, you know, other mechanistic studies and studies in rats, etc., to really build up our data. But I think where we can go, and we should have those conversations, maybe with the maternal fetal team as well, where we can go is individual shared decision making with clear discussion around presumed risks and benefits of using hydroxyurea through pregnancy. I think that's where we can go. If you talk to the likes of Professor Ware, Russell Ware, who is a close friend of us in Jamaica, he is a big proposer for hydroxyurea, and he can present a lot of positive data on the use of hydroxyurea during a pregnancy. But it's not a decision to be made lightly or by one individual. It will be a shared decision making for now. But I think we need to get to that at least, Dr. Lord.
Okay, thank you.
Right. Okay, great. Thank you. And Prof, I want you to talk a little about the strategies that we are implementing to increase the uptake of hydroxyurea,
Yes.
which is a game changer.
Good. And, you know, we have conducted the study in over, I think, 350 people already. We are actually in the middle of writing a huge grant to apply to the NIH for some money to see what strategies we can use to improve the uptake of the drug around Jamaica, right? So Ministry of Health and Wellness, through all efforts by Dr. Carol Lord, and you know, the team was well acknowledged in my presentation at SCIF last week, gave us the seed money that allowed us to do the initial studies, but we are applying for bigger money to really see what strategies we can use, both at the provider level, because I haven't presented the results of our data here today. I presented some of it on Friday last week at the SCIF conference. But both at the provider level, what can assist physicians and nurses in counseling their patients about the need to use hydroxyurea, and how can we make it easier for patients and parents to begin to use hydroxyurea in their children. I can give you a lot more details, and I hope to do that presentation to you all very soon, because guess what? You will all be partners in this work going forward, because it can't be just Sickle Cell Unit or ASNANI or Knight Madden who are speaking this. It has to be the warriors, persons living with the disease, and policymakers, because we all need to work together, because that's the only way we can get success in our initiatives. So we are thinking of different modes of improving the uptake at different points.
Okay, so we will hear more and the work will continue.
Yes,
I mean,
it is
as you
continuing.
said,
It
it is a game changer, and I think more people can benefit from it.
Absolutely. So just to say that the NHLBI guidelines, which is the National Heart, Blood, Lung Institute out of the United States, their guidelines say that babies from 9 months of age should be started on hydroxyurea, just to put things in context.
Wow.
And this is not a new guideline, by the way. It's at least 10 years old. Yeah.
Okay. Alrighty. I am looking at YouTube, and there are some comments that I want to highlight. Okay, so Sabrina Ward says this lecture is a great initiative, very informative session. May God bless and keep you all. Marjo Mundle, Nurse Mundle. I'll share her comment. Possibly we can interpret it a little better. So it says, I know the importance of newborn screening. However, I had a situation where stillbirth infant was screened not known to us until I receive the contact for the mother for all three parents and baby.
Oh. I guess she's
You,
paused
you
a
got,
little.
you understood the point?
No, I didn't understand. And Prof.
Right.
Nyman, you know of this case? Because, you know, Prof. Nyman manages that program as well. You know of this case?
No, I don't know that particular case, but when we speak to newborn screening, it's supposed to be live births. This is something that we've been trying to emphasize because it is very difficult if you've had a stillbirth, to have somebody calling you to bring in your baby to confirm. So and the point of the program is not just to, you know, the main point is not statistics. The main point is to get affected infants into care. So we really should just be following up on those who are alive.
So she made a further point.
Further
that
point.
I
Go ahead,
interest-
Moret. Yes, she
point.
made further
What
point.
she said is, when I spoke with the mother, she informed me that her baby was stillborn. This really opened my eyes, and I wonder how many stillborns are actual sicklers.
Yeah. So we do know that stillbirth rates are a little bit higher in mothers who have sickle cell disease. Okay, in mothers who have sickle cell disease, whether a baby who is born with sickle cell disease is more likely to be a stillbirth, I don't think we have that kind of data.
Okay.
Yeah, yeah.
Okay. So 2 comments on hydroxyurea. Derisa Ramsey, hydroxyurea is in pregnancy category D.
Category D drug, right?
Could you expound on that, please?
Yeah, so category D, I believe, is a no-no. So, you know, there are different categories of drugs that can be used in pregnancy. So that's the point. So we all know what the guidelines are. But,
Okay.
you know, science always has to keep developing and growing, and then things change, right? And the other point is also on hydroxyurea.
Okay. Davian Cole says, very informative and helpful information. What's the worst that can happen being on hydroxyurea?
I'm thinking about it because I read the comment. What's the worst that can happen? The fact that I'm thinking so hard means that I can't really imagine. I know there are some conflicting reports that it might affect fertility. Conflicting meaning some reports say that it might lower fertility for both men and women with sickle cell who are taking hydroxyurea, and yet there are other reports that say it doesn't go so, not go so. Other research that says the opposite. So, you know, and for a lot of people, the ability to conceive a child is a massive thing. Other things that can happen, Mr. Cole, is that if you are not quick with it, but counseling needs to be good, how hydroxyurea works is by suppressing the bone marrow. Bone marrow, the marrow is that part of the bone what you suck on, you know, when you can break the bone, that soft part of the bone, that is where your blood cells are produced. That's where your red blood cells are produced. So what hydroxyurea does is lowers those cells in the bone marrow. If they go too low, then you are at risk for infections and other problems. Now, that is a very transient side effect of hydroxyurea. That's why close monitoring in hydroxyurea is important, because we know what to look out for and how to look out for it and what to do if we find it. And it's transient. You know, we take you off of hydroxyurea for a few days and your bone marrow kicks up right back. That's why in my presentation I said most of the side effects are reversible. And then what is critical, what is an important side effect is something that's very important to the individual themselves. So it can cause some darkening of the nails. There might be individuals who just hate seeing that. Okay, but I really can't think of what can be worse. I don't know if Dr. King can plug in here with something. Leslie, what is your experience? Dr. King, you're going to unmute? Not many other clinicians are here. Dr. Ramsey is here, Prof. Nightman is here.
All right.
Yeah.
Repeat the question for me, Monica.
I'm saying the question in the chat was, what's the worst that can happen with
Worst, mhm.
hydroxyurea?
What's the worst that can happen with hydroxyurea?
Right. A very good question, but I really can't say.
Yeah. I mean, I can just tell you that from our experience, you know, the worst that has happened is, you know, it probably hasn't worked as effectively as we wanted it to, but the side effects in terms of the, you know, transient neutropenia are well documented. Some hair thinning, couple patients have pigmentation changes to their nails. But in terms of any other catastrophic hydroxyurea related events, we haven't seen that, and I can't really think of anything much documented in the literature either, actually.
Exactly. Just to say, Mr. Cole, that it speaks to the safety of the drug, the relatively excellent safety of the drug. And even when Dr. King says that it might not work, some individuals say it might not work, but we really believe that that don't say that lightly. You know, it's going to work differently in different people, and we have ways of ensuring how the drug is efficient in an individual. So your dosing, if 10 people in the room are taking hydroxyurea, all 10 of them might have different doses and different things that we need to do to make sure we are doing the best that we can before we sign off to say, boy, this is not working for you.
Okay, thanks so much, Prof. and Dr. King. Devian has made 2 more comments. He said, I've been on it and my kidney numbers are all over the place. And he added that that's what I don't like, the darkening of nails. So in response to the discoloring of the nails, he's saying, you know, that's something he's uncomfortable with.
Yeah. He said something about the kidney numbers are all
kidney
over the
numbers,
place.
right, are all over the place.
We do monitor kidney function, and whether it is due to hydroxyurea, unlikely. It may be due to the sickle cell disease, which is a lot more likely. We have said that at least 3 times in the presentation, that long-term, you know, I mean, as you age, you have sickle cell from the day you're born. So you've been, you know, as you get older, effects on the kidney can really happen, and we need to monitor. And so much so that even though there's not firm evidence, when individuals living with sickle cell disease start to show some kind of strain on their kidneys and they have never taken hydroxyurea, we put them on hydroxyurea because we know the kidney is getting damaged by the sickle cell, and we know hydroxyurea is the only thing that's really going to help the sickle cell. So check it out with your doctors, Mr. Cole. It's not necessary that it is due to the hydroxyurea, but we need to figure it out.
Okay, thanks for that. And the final comment from Tamara Mackenzie says, despite this knowledge, read the ideal timeline to commence HU. We have so many patients living with the disease that have lagged in accessing same. How can we seamlessly bridge this disconnect?
What this lady, young woman, older woman, Tamara, I can't place you. You need to come and talk to me because you're talking exactly our language. And that's exactly what we're trying to do. Understand from the patient's point of views, from the parents' point of views, what is, you know, have you ever heard of the drug? Have you ever been advised to take the drug? And for adults, for example, in the study we have been conducting for adults, out of all adults who had been advised to take it, only 2/3 started taking it. And just about half are actually taking it, right? So some might have started and just say, boy, after a week, we can't bother with this, and left it. So you see, and so number one is, and from the providers end, are we actually prescribing it? Are we telling our patients about it? So that's exactly what we want to do, Tamara. And if you have some excellent ideas about how to close this gap and stop this lag, then come and talk to us. You know, with the internet now, you can get our emails easily. So give us your ideas. Be partners.
Whoa, whoa, whoa. Hear the passion, Prof. We could continue this discussion and so much to share. We really look forward to continuing this conversation. As I prepared about a proposal where we'll have monthly conversations on issues impacting persons living with sickle cell disease. And I think we should move forward, if not monthly, but more conversation with the community. So, Prof, I really want to thank you for taking time out of your schedule to passionately and engagingly sharing your wealth of knowledge and insight with us. We have left more empowered, more informed, and more hopeful. There's just so many nuggets and so many points to consider as we move forward in how we can more effectively manage the condition and, importantly, alleviate the pain. And we know the range of pain that we're faced with. So you never say no. You never say no, Prof.
Because it's such an honor to be asked.
None of the doctors say no, but you have shared openly that I am here and I want to partner with the patients, and we really appreciate that. So as we conclude, I want to say thanks again, and we're also grateful to each of you, our partners from the Ministry of Health, from the Sickle Cell Unit, who have demonstrated, some amount of commitment to improving the lives of those who are impacted by sickle cell disease. Dr. Lord, stalwart, who, is at the rein in leading this national program. And notice the Lancet study speaks to the need for a national sickle cell program, and that is where we are. Our goal is to decentralize the quality care, and I say the quality care from the sickle cell unit into the public service, where there will no longer be that inequity in accessing care. So we are really looking forward, and we know it's a journey, but we want to see, and we've been seeing advancements, but we want the patients to feel it and be able to articulate it when the next needs survey is done or when we engage with them. But we know you're equal to the task, Dr. Lord, and we're behind you. We are all behind you in that charge. So the lecture tonight, this evening, has highlighted the fact that while the challenges of sickle cell disease remain great, there is hope in the innovations and the therapies that are being developed and researched. So as we go forward, let us remember the words of Helen Keller. Alone we can do little. Together we can do so much. So thank you again for joining us today, and let us continue this journey of awareness, innovation, advocacy, and hope. So have a good night, everyone, and stay well. Thank you all.
Thank you so much. Thanks.
Thank you. Thank you.
Great being with everyone.
Bye.
Good night. Stay on, Prof. and Dr. Lord.
Yes.
Thank
Bye,
you.
Dr. Lord. So good to see you.
Yes.
Still live streaming or we've stopped?